Welcome, everybody joining us to Meadows Behavioral Healthcare Continued Education with Kara Fowler today. My name is Bianca Brems. I'm one of the business development liaisons here with Meadows Behavioral Healthcare. And I would like to welcome you and get us started with a brief few housekeeping items. Your continued education credits will be sent to you via email. Please watch the chat session. There will be a link posted to the evaluation form that you will need to complete and submit in order for the CE certificate to be sent to you later on this week. We will be continuously posting that for you in the chat section. I would like to also start with giving some information about the program that is hosting the chat or the session today. The Meadows Seasons is a new program that is part of the Meadows Behavioral Healthcare family. And Meadows Seasons meets two distinctly different needs under one roof. Providing a reliable and clinically guided setting for short-term stabilization and a gentler environment for highly individualized treatment, all done with the extensive experience and expertise that comes with the Meadows name. Meadows Behavioral Healthcare is an innovative and specialized family of programs designed to provide comprehensive care for individuals struggling with trauma, addiction, and eating disorders. We are located in beautiful Wickenburg, Arizona, the roping capital of the world, fun fact. And today's presenter, I'm delighted to present you, is Kara Fowler. She's the Executive Director of our Eating Disorder Services at the Meadows Seasons. Originally from Dallas, Texas, she is a double threat. She is a registered dietitian and a licensed professional counselor, specializing in the treatment of eating disorders. Kara joined the Meadows family in 2023 and has an extensive background in working with individuals with eating disorders and their families through all levels of care. So with no further ado, I'm going to turn this over to Kara. Thank you.
Thank you, Bianca. And hello, everyone. Thank you for being here. I'm so glad to have the opportunity to speak on this topic, especially during Eating Disorder Awareness Week. I've often been referred to by some of my friends and colleagues as someone who likes to work with people dealing with complicated problems. And honestly, it's always felt a little bit surprising when somebody would say that, because as I would imagine the vast majority of you know or have experienced also, I just don't know that I have been aware of a person dealing with an eating disorder that wasn't also dealing with, at least a couple of other issues, often involving the impacts of trauma. So, people's determination and ability to heal despite sometimes overwhelming symptoms is always what stays with me. And, it's such an honor to do this work and to work with people like yourselves. And I have no doubt that probably we all feel that same way. I am especially excited to be here and part of the Meadows Eating Disorder Programming, which we do have, as Bianca mentioned, now in our in residential settings, as well as our outpatient centers, where we're implementing treatment using the concepts and framework that I'm talking about today. So let's jump in. And to start with, we're just looking at why trauma-focused. And research continues to confirm significant levels of trauma histories in people with eating disorders. And the evidence certainly supports that it's more common than not for people with eating disorders to have a trauma history. And so approaching treatment from not just a trauma-informed lens, but a trauma-focused lens can make all the difference. As understanding of trauma treatment expands, And the options for trauma modalities expands as well. Trauma-focused pathways to eating disorder recovery actually can be implemented from the very beginning of treatment across all levels of care. And so that probably still challenges, some of the messages that I know not just patients, but clinicians were presented with for years, with that double bind of, well, in order to recover from the eating disorder, we have to be able to address the trauma, and we can't address the trauma until people are well into eating disorder recovery. So trauma-focused pathways to recovery engage active exploration of symptoms and patterns of behavior that may stem from trauma-based beliefs and experiences. And they use interventions that help build new, healthier ways of interacting and caring for, the self, others, and just relating to the world. So trauma-focused pathways in eating disorder treatment often work most broadly with a focus on implicit trauma-based memory and individualized attention to the need to address explicit memory, those types of memories that we think about when we think of trauma symptoms, flashbacks, nightmares, as treatment unfolds. So when we look at implicit trauma and the impact with eating disorder patients, we're probably interacting with implicit trauma-based memory most sessions with patients and clients. And it can be really helpful to try to start identifying those and help the patient or your client identify them as such as well. And so some of these thoughts or beliefs include things like, I can't trust my body. If I'm not this certain size, then I'm not okay. Whether that means I'm not safe, or I'm not going to be accepted, or I'm not going to get the job I want or the partner that I want. Beliefs about emotions, like, good people don't get angry. I'm sure we've all known people that have taken a message in so strongly that they are completely disconnected and truly present saying like, yeah, I just don't feel angry. I don't ever feel angry. I don't even know what that's like, as opposed to a person that may always feel angry. Both of those things can relate to implicit trauma-based memory. Not deserving, that can relate to withholding from the self or withholding from others, beliefs about exercise or other self-care aspects of life that relate to the eating disorder and tying it to character traits, as well as behaviors, having difficulty sitting down or eating at a table with others, people that are unable to go to a party or a dinner out. Any kind of compulsive movement, compulsive exercise, other purging activities, and what looks like self-sabotaging progress that somebody's made towards recovery goals. All of that can relate to actually that implicit trauma-based memory. So when we see these kinds of symptoms, they're just big flags that let us know, okay, let's pause here and be curious. Where did they learn this and how? Is it something that they're seeing modeled currently around them? Is it something that they think is true for others? Like, it's just a time to slow down and really try to understand it before we decide the best way to intervene. And then I'm putting this up. This is probably many of you are well familiar with Stephen Porges's polyvagal theory. And implicit memory often relates to what a person with an eating disorder and trauma history may continue to experience in their nervous system, whether it relates to events that may still be happening somewhere in their environment, or whether it relates to experiences from a long time ago. And having this in mind can kind of be a unifying concept to use in helping someone with their eating disorder, as well as co-occurring issues. And this graphic just summarizes the overall concepts of polyvagal theory, which describes nervous system states, depending on whether we're experiencing safety, danger that we need to act on, or danger that we don't sense being able to escape. Each of these states directly experiences our, or directly affects our experiences of our bodies, our needs and interactions with others, and helping clients identify and work with these states can be transformational. Puppies. So this is just my reminder to pause and take a few seconds just to demonstrate how simple a trauma-focused intervention can be, regardless of what setting you're working in. And just pausing at various intervals as you're interacting with a patient or client, and just to explore like what's happening for you right now as we're talking or as we're working on this, can be extremely important in just helping to build awareness about where people are, like on that autonomic ladder that we just looked at, and provide the opportunity to either explore it a little bit, if there's awareness of maybe what they're experiencing in themselves connects to, or if it's just opportunity to connect to a resource to see like if they're aware of being in kind of a default pattern of always being tense and on guard, are they able to, take a sighing breath, just notice what it's like to take a pause and give themselves permission to resource a little bit. The point is to just orient the nervous system to new opportunities for connection or rest. And we can use that education about and link it to what the habitual patterns in the nervous system might be as a way of working with their trauma, without having to pull them into talking about memories or getting into anything that's further dysregulating. It's just in the moment interventions. And so coming from a trauma-focused perspective really helps ground the work of treating additional comorbidities that people with eating disorders often have. Comorbidities just meaning the presence of two or more physical or mental health problems. And, again, internally, even when I see like presence of two, I'm sure that a lot of us have regularly seen people who've come in and they'll have a list of 10, right? Physical or mental health problems. And I've always appreciated the perspective at times in such cases where, we can just work with that person by narrowing the diagnosis down to majorly stressed human, because that's really what a lot of these different compartments boils down to, right? So I am going to review a few of the most common comorbidities that are seen in people with eating disorders. And these are often the most relevant to screen for in order to fully inform your treatment planning. But again, you see these statistics. If you have somebody that's sitting in front of you with an eating disorder, they probably have at least one, if not several other struggles that they're dealing with as well. And it's complicated by the fact that trauma is linked with many of these comorbidities too. So it can get very layered. So anxiety disorders are actually identified the most frequently overall as a category. And they often precede the onset of an eating disorder, which differentiates them in some ways from some of the other comorbidities where it's a little bit fuzzier as to kind of which comes first, the chicken or the egg, and the impact of probably of malnutrition is really a driving factor. But with anxiety disorders, it's not unusual for OCD to be diagnosed prior to the development of an eating disorder. And co-occurrence of OCD does usually indicate increased eating disorder symptomology and can be very tough to resolve and tease out because they maintain each other with the high level of intrusive thoughts and perfectionism. Social anxiety as well is very common. It's highest in bulimia, followed by binge eating disorder and anorexia, binge purge type. It often acts as a barrier in accessing eating disorder treatment. And so it's important to screen for sometimes people that are dealing with a lot of social anxiety and are masking it through the eating disorder. It can be hard to unravel that, but it's important to look for. And then generalized anxiety disorder, there's actually a possible genetic link, and all of the research that's coming out about genetics and eating disorders is so fascinating. And I think we're going to really benefit from what all of that continues to tell us and hopefully inform different treatments as well. Again, like there are links between generalized anxiety disorder and fasting, excessive exercise, low BMI, and then the eating disorder as well. So this one in particular, as opposed to OCD and social anxiety, there may be more of an impact of nutrition on the development of it. Okay. So mood disorders, this is one that there is a lot of evidence indicating that major depression and the eating disorder may develop more at the same time. And, we can go back and think about the Ansel Keys study. That's a really fascinating study if somebody's not familiar with it. It's a study in the 40s that they looked at. They were looking at the effect of semi-starvation on college-age men, strictly with the purpose of examining the physical effects of semi-starvation and wanting to know how to appropriately refeed people for safety. But the first symptoms that they actually saw as they put these men on pretty strict diets were what we think of as emotional or psychological symptoms, discounting the physical aspect of that. And so depression, anxiety, those types of things, personality changes were very prominent. And there's definitely continued support for the impact of nutrition on our mood. Bipolar disorder, I think, we see frequently in eating disorders, although there's a lot of mixed evidence about the actual frequency of association. It as applies to actually many of the common comorbidities. It's seen in eating disorders, more eating disorders with a binge or binge purge symptom profile, and definitely appears to impact symptom severity and daily functioning. Substance use disorders. We see actually PTSD and substance use disorders at similar rates, up to about 27%. And when you look at people that are in residential treatment or inpatient treatment, that rate jumps to 50%. So alcohol, stimulants, sleep medications are some of the most frequent substances used by people with eating disorders. And sleep medications in particular is something very important to ask about because people often don't volunteer that, or they discount it. They say they don't count it as, a drug, a substance. But a lot of people with eating disorders that may be abusing sleep medications are using them to sleep instead of eat. It's another way of suppressing appetite. And just getting more into PTSD and trauma. Again, kind of across all demographics, 25% of people with eating disorders, again, across all eating disorders and across all the demographics related, 25% meet criteria for PTSD, and that's higher in people with bulimia. And then again, just to repeat, the incidence of and how things can mirror the incidence of substance use disorder. In inpatient and residential treatment, if people with an eating disorder, there's a 50% comorbidity rate with PTSD. So 81% of people with a lifetime eating disorder, meaning an eating disorder that started in childhood, had at least one traumatic experience. And some research indicates that there's also a high prevalence of dissociative disorders in people with eating disorders as compared to other psychiatric populations. So personality disorders. Personality disorders, the research, you can find research that actually has a pretty broad spectrum of possibilities as far as the frequency of personality disorders being diagnosed and which ones. Some research indicates a diagnosis of personality disorders that exceeds 50% comorbidity. And some of the common examples there, borderline personality disorder, obsessive compulsive, and antisocial personality disorder. I just want to emphasize that it's really critical to approach these presentations from, number one, an attachment and complex trauma lens, because there's so much overlap in symptomology, and including consideration of a dissociative disorder being present, and also consideration of the impact that malnutrition has on the brain and nervous system functioning. And so we want to be really careful about putting a diagnosis of a personality disorder out there. Again, depending, of course, on how the individual patient or client is relating to it. What sense are they making of it? What sense are people around them making of it? And, looking at where is that person in treatment? Probably, again, the majority of people who have worked with somebody with an eating disorder who at the beginning of treatment usually is dealing with a very malnourished nervous system and brain. And remember that being malnourished can occur regardless of weight, body size. It's an imbalance in nutrients and vitamins and hydration. And it impacts how well our brain works and how reactive our brain works and how we're experiencing other people. So, we want to be very careful about identifying somebody who's having a really hard time as having a personality disorder when they might just be extremely malnourished and need physical and medical, treatment and rehabilitation. We've all seen those situations, fortunately, right, where a person gets a little ways into treatment and they are stabilized, and it's like, oh my gosh, I have my family member back, or I have my child back. I didn't even recognize them, or I didn't recognize myself, and so that's not personality. That's physical complications. So We want to use diagnoses to understand what may be needed and not to identify certain traits as fixed. So that can come into play when it may be, and there can be reasons, of course, why it's helpful to identify a personality disorder. And especially if the person is also dealing with trauma-related symptoms, we still want to use whatever framework that we're going with as a way to build a plan to address what's needed and not to communicate with a family member, or the person that we're working with that this is something that's not going to change, because unfortunately there's a lot of evidence out there in these complicated presentations that supports the reality that change is usually possible. So ADHD and neurodivergence in general. With ADHD, there's a twofold increased risk of ADHD in individuals that have an eating disorder. And ADHD may or may not have been identified. There are particularly strong associations between ADHD and bulimia. And so it can be important, again, with this situation, to really tease out what's going on. The effect of being malnourished on the brain and the nervous system can certainly create symptoms that mirror those of ADHD. And so can trauma-related symptoms as well. There is more and more research coming out helping to clarify that ADHD in its organic form certainly exists and coexists in people with trauma-related problems and also in people that have eating disorders. And so we just want to be careful in teasing out what's what, so that we can treat appropriately and that we're not avoiding treating something that may actually be helpful in regulating somebody's mood or appetite or ability to function. If it's somebody that, again, like had an organic and genetic, usually ADHD present from very early on. So, and that's, of course, there's always a lot to consider in the eating disorder field. It used to be that it was a pretty all or nothing, like we're not going to treat ADHD, or certainly with stimulants. And there's a lot of growth in the field in looking at, in what situations is it warranted or not. And then mentioning physical and medical comorbidities. Just wanting, what I really want to do, I'm not going to read through all of this, but there are many physical and medical conditions that are definitely related directly to the experience of having an eating disorder and are significant health risks. And what I have in red are trauma-related physical comorbidities, just so that you can see that, there's such interactions here. And so there's a lot of research still going on in looking at, what do we attribute directly to eating disorder, specific behaviors, what involves a larger picture maybe of the impact of stress, trauma, and the interaction of those two. It's a complicated picture, but these are all things that can affect certainly somebody's quality of life, length of life, and risk long-term. So it's important to be monitoring those and incorporating treatment of any of these that exist when we're working with a patient. And then I also just want to mention self-injury and suicidal ideation, because it is so common. again, recent studies indicate that up to 61% of people with eating disorders also do engage in self-harm. And it may serve as a way of helping to buffer against emotion. It may serve as self-punishment. It may serve as trauma reenactment. Sometimes it can be something that people are using to distract from hunger. Being curious and is really important. And if somebody is experiencing suicidal ideation, always important to pay attention and be curious and tracking, and to notice if self-harm urges or suicidal ideation is escalating as they're trying to make changes in their food or changes with any other behavior as well. Just if somebody's making strides in achieving sobriety and their suicidal ideation is going up or self-harm urges are going up, it's all indication to just, slow down and pace. And not meaning slow down in efforts towards sobriety, but just to slow down as far as leaving space to really focus on, how do we help and what is needed towards increasing emotional capacity, ability to self-soothe, those types of things. Because high levels of distress are always important, even for the person that may consistently report, they're always an 8 at level of intensity. That matters. And so that slower is faster mantra is really important. Okay, we have kittens. It's just a reminder again, take a pause and check in with yourself right now and see you need to shift at all in posture, awareness of needing to get a drink of water, just a little mindful moment. And so when we look at considerations in the concurrent treatment of eating disorders and co-occurring disorders, there's some, just summarized some of the main aspects of individualizing some of our treatment that seem to make a real impact, right? Making sure that there's support, certainly for if somebody needs detox, then we're speaking to people working probably in residential and inpatient centers. But being aware of multiple medical needs, looking at what the risks are for more nutritional deficiencies, for having a more difficult detox if the person is extremely malnourished from their eating disorder, and being prepared to treat all of that, needing modifications in initial meal plans to allow for and ensure adequate nutrition, not having unrealistic expectations of what somebody's going to be able to challenge themselves with. Having psychiatric support, including expertise in a variety of conditions and presentations. And between both of those, looking at what's needed from psychiatry and medical perspective, if there are additional physical conditions to be worked with and included in the care. If somebody has diabetes or some other condition, that needs to be actively a part of the treatment plan as well. And then looking at the meal plan considerations, including food exposures that were guiding a person through. So things to consider in the interest of supporting autonomy, supporting just increased awareness and rapport building and trust. So consider supporting rapport. If somebody comes in saying, hey, I'm gluten sensitive, this happens, my throat swells, whatever it is, and no, I don't have a biopsy and I don't have a medical test saying so, consider working with that, perhaps, if it doesn't involve eliminating entire food groups or adequate variety. And then as the person is more stable and more trust is built, perhaps it can work towards exploration of that. And considering support with flexibility if there are certain foods or certain times of day that are the most activating of trauma-related symptoms. Differentiating between what may be a very appropriate and effective kind of OCD-based protocol for food exposure versus somebody who has no idea what it's like to be in a space where their nervous system has any sense of safety. And we're really needing to facilitate the development of that in order to promote even just healthy digestion and processing of food. That person's food exposures may need to look a lot different. And then looking at vulnerability factors too, as far as what's realistic with meal planning from an outpatient basis, depending on somebody's energy level. Are they needing to avoid certain environments socially or food purchase wise if they're also in recovery from substance use disorder? These are all important considerations. And so identifying collaboratively, what supports safety and autonomy, even when we're looking at things like monitoring or having the patient track what they're eating and, looking at what is needed. For somebody dealing with trauma symptoms, often it's, what provides the least restraint within a consistent container is what can be the most helpful. So, looking at, what's helpful, even from a residential standpoint. For instance, we are individualizing our bathroom monitoring and creating very individualized plans around that so that we make sure that, the support is there for the people that need it in the way of having very close monitoring during time in the bathroom, and that for people for whom that's just going to activate them and escalate symptoms, we can make a different plan. Also individualizing weighing protocols, whether that's frequency or consideration of times that it may actually be helpful to share a weight. And that's where, again, differentiating what's going on. Does this person have, those repetitive, out of control, kind of OCD-based thoughts about their weight? Or is what's actually needed for them is to be developing a sense of knowing what's happening in their body, and they're not fixated on the numbers so much. So flexibility is key. And then direct treatment components addressing the other comorbidities, individualizing needs and activity or movement, and several variables can be considered there, but we're not wanting to avoid activity. And then, this takes up the whole page, but I'm throwing this up because this just depicts some of the main concepts that we use at the Meadows, specific to the Meadows model, that supports a trauma-focused approach to eating disorder treatment. And so, just linking the information that I just went through to the rest of the material that we'll finish up with. This kind of pulls together the fact that by working collaboratively and directly in a variety of ways to identify and heal wounds that often occur in the core issues as defined by the Meadows model there on the left. It's often wounds in these areas that result in a lot of the problems that contribute to development of an eating disorder, development of substance use disorder, and difficulty relating we're wanting to support the development of a functional adult self that can connect to all of those experiences down that third column. And so all of our interventions from, medical to nutrition to therapy, we're wanting to facilitate that growth. And so with trauma-focused eating disorder treatment, what we're shifting to from that standpoint of the Meadows model is differentiating. When is it appropriate for somebody to be more focused on a past event as part of their trauma treatment versus experience-centered and focused on, realizing and I've got remembering in a separated form there, because what we're really wanting to do in a remembering process is to reconnect to parts of ourselves that trauma may have disconnected us from. So we're wanting to be able to help people connect back to experiences of hunger and fullness, or awareness of emotion, or understanding that, oh, yes, I learned to think this way about food, about my body, about, whatever, because of the circumstances that I was in, with a focus on now, what is possible now and what is real now. And so we oftentimes in eating disorder recovery are going to be more focused on the right half of this graph, with experience-centered, regulation-centered, that brain and body-centered, and a slower is faster approach to working with any explicit memory that involves thinking about past events or contacting any of those really intense emotions, where we're taking an approach of stabilizing first, titrate the amount of material that we're working with, allow time to metabolize. And so considerations, summarizing this slide, really can be looked at overall from the perspective of it being just so important to really differentiate, what kind of needs does my client or my patient have, considering where they're coming from. Is this somebody who's had a pretty stable experience of growing up, but had some traumatic events that were either out of anybody's control, or involving people like outside of their core support group? Or was this somebody who got through, their entire growing up years in an environment that was completely unpredictable and frequently unsafe? Those are going to be different needs for eating disorder recovery and trauma recovery. And the eating disorder was probably often helping somebody, or helping that person that grew up in an unsafe environment to buffer some of the strong emotions, some of the needs for safe connection. And these people often may look like they have more capacity to regulate than they actually do. So, because as we know, like, eating disorders are often complicated by traits of perfectionism, the desire to please, to do things right, fears of being held back from different aspects of treatment. So taking things slow and staying connected and being curious about what's going on is really, really important. Validating the reality that trauma recovery work is eating disorder recovery work, and vice versa. And helping people make links between their eating disordered patterns and trauma-based beliefs or experiences of their body while staying grounded in current day and resources. It's transformational for many. So other things to look at, looking at a capacity. This is about, well, how do you tell? How do you tell if somebody, looks like they can manage more than is actually useful? So looking at, do they feel okay feeling okay? And that's for a very chronically traumatized person. They often have such a tiny, tiny space there for that window of tolerance. Like it actually can be activating to try to have a sense of relaxing or trusting somebody, because those things may have put them in danger over and over growing up. And so being able to, for somebody that has trouble resourcing or self-soothing, that's somebody that's going to need to take a more graduated approach and graduated interventions to trauma recovery. So, what's their overall capacity for reporting a coherent narrative in any way, even for the last, couple of years? And do they have a continuous sense of self? Are they consistently staying medically and nutritionally stable? And as they get better nourished, do they have an easier time with emotions or more difficult time with emotions? Because we tend to think a lot of times that things should get easier as somebody gets more well-nourished. And that can be true, especially oftentimes for people that have been in hyperarousal and overactivation. Being better nourished more quickly helps them regulate that intensity down. But for somebody whose primary defenses in surviving trauma has been shut down, getting better nourished may be bringing them and their nervous system up to a place of feeling more, and they're going to be hitting that place of overactivation before they're really able to reach to gain the skills to also develop capacity for calm. And so that person is going to need, again, probably more of these interventions that are more graduated, designed to treat complex trauma symptoms. So these are all really important considerations. And these body-focused interventions are fabulous for helping to build that window of tolerance and helping people develop a soft place to land. I'm just going to emphasize the 2 points that play is really important to create, and doing that in session can be really powerful as well. That's why, humor in sessions, moving out of intensity for moments here or there can be so important. And encouraging actually the use of some sensory tools at times around eating can also be really helpful. And it does not need to be like a distraction or a way to get out of eating. And so stepping into helping people experiment with that. Oh, my last picture, the ocean. So we're moving through all of that material, and I have just a couple of examples, and I want to stop and see, make sure that there's time to see if anyone has questions or comments. But I've got just a couple of case examples that kind of pull together some of the concepts that we've talked about. And one is a 20-year-old male with ARFID and substance use disorder, actually his primarily marijuana and alcohol. And his food exposures were modified with regard to type of food and time of day after learning that mornings were difficult, specific to trauma-related experiences. And we actually also distributed more of his nutrients, more of his macronutrients away from breakfast. He had been trying to eat breakfast and then consistently not being able to keep it down. And so we just, worked with him to see what allowed him to, successfully renourish himself. And he was able to restore weight in a linear fashion and significantly expanded his variety and volume after the expectations at breakfast were removed. So his trauma recovery work focused on somatic interventions and facilitating, experienced increases in autonomy and self-esteem. Family work was really important, and some of his groups, of course, in treatment, but aftercare emphasized as well the need for support groups around his substance use disorder, as well as making sure that he was plugged into eating disorder specialized providers. And then one more, an active duty female with bulimia. You can see a very complicated childhood history, and as well, a high anxiety about really wanting to maintain performance requirements to stay in the military. Some of that did involve also a lot of anxiety about her weight and the requirements that the military has around that. But we're able to help her engage in, an active coping plan related to urges, and worked with her around privacy using the bathroom. That was very important to her. And she was able, pretty much from the beginning to engage in a lot of taking initiative in letting us know what was going on, what did she need, and experimenting to develop a range of skills to, shift that behavior of purging. We worked with her around exercise and her requirements to maintain a certain level of fitness for the military, and used parts work, internal family systems primarily, and helping her learn safe ways to self-soothe and express anger. Did very well. And then I will finish really with this is pretty much a direct quote from this patient. This was, and just recently. And this is what it's about, right? We're wanting people to be able to actually focus on themselves and their own experience and feel appreciation for themselves and increase confidence in themselves by creating a container where, we're facilitating people being able to approach emotion, connection, contact with safe boundaries versus pushing away from their experience or an expectation of external control. And that's where healing happens. So that's what I've got. I want to thank everybody again for being here. I love talking about this work, and if there are any questions or comments, I'm glad to respond.
Thank you, Kara, so much. Brilliant information you shared. There are a couple of questions. If you can look in the chat for panelists, for hosts, they're listed in there if you have time to address maybe one or two.
Oh, okay. the first question says, many patients with anxiety disorders experience GI issues. Are these patients more at risk of developing an eating disorder over patients who do not have GI symptoms? And yes, I think that it's so interesting. There's so much that we're learning and have learned about the GI symptoms and the range of gastrointestinal disorders out there, and there's so much that's interesting, at least to, I can become, I guess, a science geek really quickly. So much involved with immunology and all of that. And it actually, there are different, and I don't have those on the top of my head, but there are different statistics as far as type of GI disorder and the risk for developing an eating disorder. But there definitely are increased risks, and especially for people who may have something that, like celiac disease or a metabolic disorder that impacts their GI tract in some way. It definitely does increase risk. Let's see. So this is a great question. I think that this is a very discerning question, and common also. So looking at whether morbid obesity is considered an eating disorder, right? I bet we could have a fabulous 2-hour discussion just on that question, because it involves so many social and physical and medical factors. But actually, any of the categorizations related to weight are strictly medical related categories. And because we can't diagnose an eating disorder without assessment of what's behind the etiology related to social factors, emotional factors, physical factors, behaviors. So it's actually not. It may be the case that somebody that falls into a higher weight category may have an eating disorder, but it's not an eating disorder itself, just the weight category. Yes, and there are actually multiple eating disorder diagnoses that are present or that are just defined in the DSM-5 now. But if you go to if you go to NEDA's website, the National Eating Disorder Association, that's always a good resource, and they will describe all of the categories.
Thank you, Kara, so much. I know we're right at time, and I know attendees have to drop off for other appointments, perhaps.
Thank you.
Thank you again. Please, everybody, if you could click the link for the CE evaluation, the completion and submission of that will trigger the certification to be sent to you. It'll probably come in later this week. We also posted a link to an event that is happening virtually tomorrow, hosted by our senior fellow, Jennifer Schaefer, who is the author of Life Without Ed. Kara works closely with her, and this is really a free online event for those who are struggling with eating disorders or may have a family member, and it is also for clinicians or anybody that is curious. So please go ahead and check out that link as well. We thank you for attending, and we hope you join us again next time.